So the clinical context in which these two abstracts were presented at San Antonio this year were based on the data that we already have now from several trials demonstrating that patients who have progressed on first-line therapy with CDK4/6 inhibitor in combination with endocrine therapy, a subpopulation of these patients do derive significant benefit from the continuation of CDK4/6 inhibition beyond progression. That's exactly the context of the PACE trial, which was a phase 2 trial enrolling patients who had already progressed at first-line therapy with CDK4/6 inhibitors and endocrine therapy, and then they were randomized into one of the three arms, being fulvestrant, or fulvestrant in combination with palbociclib, or fulvestrant in combination with palbociclib and avelumab. So the two analyses that we did today were particularly interested in looking for predictive biomarkers that would tell us which patients would derive significantly more benefit from this approach. And we were interested in specifically in studying liquid biopsy biomarkers because these are easily accessible and non-invasive ways of trying to understand which populations would have more benefit. The first analysis was done with a ctDNA-based analysis classification called DNADX, which is a classification that divides patients into 5 separate groups. And we did see that in terms of the prognostic value of this assay, patients who had luminal high subtype had worse prognosis. So there was a prognostic value that was found. And not only that, but we also saw that patients who had a tumor fraction above the median value had significantly more benefit to palbociclib continuation. So that should be an interesting finding in terms of the predictive value of this assay. The other analysis we did was with a serum biomarker that is also measured in the blood called thymidine kinase, which is a cellular proliferation biomarker. And we also saw that the interesting finding about this analysis is that when we measured this biomarker at C2D1, so after the first cycle of therapy, patients who had low TKa, this biomarker, had better long-term outcomes. So it was a prognostic biomarker that could be assessed really early on after the treatment starts. So could tell us which patients have more or less likely to have a long-term response to the therapy based on an analysis that we're able to do at the beginning of the therapy. And not only that, the only interesting finding we had was that the dynamic variation of this biomarker comparing baseline to the second cycle 2 D1 was also associated with prognosis. So patients who had a high baseline TKa but then had a low value at C2 D1 also derived significant benefit from significant better prognosis in terms of PFS in this trial. So what we expect to see, what we expect with these analyses is to continue trying to develop and to develop better and better predictive and prognostic biomarkers that would help us select patients for this strategy of continuation of endocrine therapy in association with CDK4/6 inhibitor after progression to first-line therapy.